of PYOGENIC SPONDYLODISCITIS in a diabetic female, a case managed by posterior spinal stabilization, biopsy, and specific antibiotic therapy. So my patient was a 48-year female who was diabetic on medication, presented a complaint of back pain with intermittent fever since last 3 months, and there was difficulty in walking for long distance. On examination, there was tenderness at T12-L1 level, and bilateral lower limb power was reduced 4 by 5, and there was mild spasticity in the lower limb. So for pre-op evaluation, we did an MRI for the patient, which showed evidence of spondylodiscitis at T11, L1 level with abscess. The therapy markers were raised for the patient, and the HbA1c was also raised to show she was uncontrolled diabetic, and hemoglobin was less with no identifiable cause. So we made a diagnosis of infective spondylodiscitis in a case of uncontrolled diabetes mellitus. So we started treatment with we started the patient on insulin therapy for diabetic control and pre-op optimization, and blood transfusion was done to treat anemia preoperatively, and the blood parameters were there, then reduced to normal. Then we opted the patient for decompression and posterior stabilization with venting rods and pedicles from T11 to L2 level, and this material was taken from D12 L1 junction, sent for biopsy and microbiological examination. Culture came positive for MSSA, and as per the culture report, we started the patient on antibiotic therapy, IV linezolid and levofloxacin for 2 weeks, followed by oral linezolid and levofloxacin for 6 weeks. Treatment of diabetes continued in the period, and we followed up the patient with serial CRP and TLC, which showed declining trend at 6 weeks. The CRP came down to 0.4 and TLC to 9,200, and the diabetes was also controlled for the patient. At follow-up for 6 months, the patient's back pain VAS were reduced from 7.6 pre-op to 1.3 post-op. The lower limb power was also gradually improved to 5 by 5 at 6 months follow-up. The patient got good diabetic control. There was no recurrence of fever or other signs of infection, and X-ray at 12 months showed complete fusion of the spine. So take-home message from this case are that diabetes and anemia are risk factors for infective spondylodiscitis, and early stabilization prevents neurological complication with improvement in muscle power, and good diabetes control should go hand in hand with treatment of spondylodiscitis, and good diabetic control and adequate antibiotic therapy can prevent recurrence in cases of spondylodiscitis. Thank you, sir.